Thank you, Jenny. Thank you so much for that kind introduction. And good afternoon, good evening, and to all of you, and a warm welcome to all the participants. I think it's my pleasure. I would really that I'm here, and I would like to say thank you to Jenny and Dr. Priscilla Rupali, who's my mentor in my institution and also one of the governing board members of the Asia Pacific Society. So without wasting time, this will be the overview of my presentation. We'll speak about vector-borne diseases, what is the burden of the disease. I'm going to just list out some of the vector-borne diseases which are important among the travelers. Then we'll talk about malaria, dengue, and rickettsial illness. And then to conclude, my presentation will be a conclusion slide. So we know that international travel is fun and it's very rewarding, and it is also a time of experience, of experiencing other culture and languages. But we have to be also aware of the risk that we have with vector-borne related vector-borne illnesses, which also comes along with international travel. So according to the WHO fact sheet, we can see that vector-borne diseases account for around 17% of all the infectious diseases and causes around 7 lakh deaths annually. And it has the highest burden in the tropical and the subtropical countries. And it also has a huge impact on the global travel and trade. And dengue and malaria are some of the important ones which top the list. So if you look at what is the burden, so I try to look at what are the major diagnoses in returning travelers. So I could get this paper, which is slightly older, but in this, according to the GeoSentinel sites, we see around 40,000 ill travelers who report to the GeoSentinel sites, and the maximum travelers who belong to Southeast Asian and the Central Asia group. So Asia Pacific forms a large chunk of the travelers who report illness. And in that list, malaria, and of course, Karen has talked about waterborne diseases, dengue, and among the vector-borne diseases, malaria and dengue are some of the most important ones. So just to list out the vector-borne illnesses, it's a busy slide and I'm not going to go into details. We need to know about what are the vectors. So mainly the different types of mosquitoes which cause various diseases, especially to the Asia Pacific area. Are the most important among them are chikungunya, dengue, Zika to a certain extent, filariasis, which is not so important in acute, but however should be remembered in chronic travelers, and malaria and dengue and Japanese encephalitis, they form the major chunk. Coming to the other vector-borne diseases like vectors like flea, sandfly, and ticks. So these are some of the list of the diseases. And we will come back to the most important, which is malaria. According to the global estimate, there is around 20 million cases of malaria globally and around 4 lakhs deaths every year, and most of the death is among children. So pertaining to the travelers, we will look at what is the incidence of malaria among the travelers, and the risk, or how should a traveler be aware of the risk, and then subsequently prevention of the bite, chemoprophylaxis, and recognition and diagnosis and treatment of malaria in a returning traveler. So when we look at incidence of malaria, so approximately malaria is endemic or prevalent in around 91 countries around the world. And every year around 125 million international travelers travel to these countries, and that's why they are at risk. So, and we see that with the passing of year, that international travelers, they fall ill with malaria while visiting these countries which are endemic in malaria, and over 10,000 of them report after returning from these countries to be infected with malaria. So we need to, when a traveler is planning its travel, we need to be very particular. I think Jenny has alluded very well how the pre-travel clinic is important, and it's very important that we looked at the itinerary or the place that we are traveling. What are the risks of a particular disease in that place? So awareness is very important, and mainly travelers who travel to these endemic areas of malaria, so non-immune travelers are much more at risk than semi-immune travelers also who visit friends and relatives. So basically they have been there, or they originally belong to these areas, but they forget that they have not been staying there for a long time. So people, when they visit friends and relatives, they are also at risk. And most of the places when the travelers who acquire malaria is mainly because of the poor adherence of the chemoprophylaxis or that has been given to them. So they all visit the pre-travel clinic, they take the chemoprophylaxis, but however, when they come visiting friends and families, they forget those prophylaxis, and that's when they come down with the disease. So that risk is very important. And special attention has to be given to special population like pregnant women, children, and travelers with comorbidities. The second important thing is a prevention of the bite. So we must remember which area are we visiting, what is the risk of malaria, is malaria more common than dengue, what are the time of the bite of the mosquito can occur. But usually try to avoid outdoor activities between dusk and dawn, which is the most important time when you get bitten by the malaria by female Anopheles mosquito, and that's when you can prevent malaria. Wearing clothing can reduce the exposed skin and can thereby prevent malaria. Very important to use an insect repellent. So important to choose the repellent very carefully. So there are various repellents and insect repellents which are available in the market. But however, choosing the most appropriate is very important. So a mosquito repellent containing DEET, picaridine, and IR3535 are the most important and the most important ingredient to have them as one of the insect repellent. So we know that DEET prevents at least if they are in the percentage of around 30 to 50%, it is protective for 4 hours, and a lower percentage can be protective for a shorter duration. However, and it is safe among the insects and children. When we talk about picaridine, it is a synthetic repellent, but there is a comparable study where 20% picaridine is as compared to 35% DEET and gives a protection of around 8 hours after the application. IR3535 is another ingredient or an insect repellent, which has a protection of around 8 hours if the concentration is more than 15% or higher. OLE is another effective repellent. People talk about even eucalyptus oil, but it may not give adequate protection or for a long number of hours. And one important thing to remember while applying the insect repellent is repeated use is definitely required. So it cannot be applied once and then, forgotten about it, because the protection is not very long lasting. It is protected only around 4 to 8 hours after the application. Other preventive measures like the use of bed nets treated with insecticide, and we know the other important ingredient is permethrin, where permethrin treated clothing and bed netting can actually help us avoid mosquitoes for almost more than a week. And there are use of nets. So these are standard nets which are dipped in permethrin and can be effective as long as 3 washes, or can withstand around 20 washes depending on the concentration and the percentage of permethrin used. Long-lasting insecticide impregnated nets are another effective tool, and some of them can be used for as long as 3 years. So this can be important in travelers who are traveling for survey purposes or study purposes, or who plan to stay in these areas for a longer duration of time. But definitely staying in well-screened or air-conditioned room prevents a traveler from a mosquito bite and thereby prevents malaria. Coming to chemoprophylaxis, which is one of the important aspect of prevention of malaria, but we must remember that this has to be done along with the other preventive measures that I have talked about in my previous slides. And one important thing to remember is that not all anti-malarial or prophylactic regimen can give complete protection. So it's very important that we prevent bite, we avoid the vector along with chemoprophylaxis. And also important to know when a traveler is advised or using chemoprophylaxis, especially when traveling to areas which are in Southeastern Asia or the surrounding areas where there is resistant malaria, and it can be different types of malaria like chloroquine resistant falciparum malaria, or even artemisinin resistant malaria can also be prevalent in these areas. I'll be talking about them in my subsequent slides. And important to look at drug interactions when given chemoprophylaxis. So a traveler who's already been on medications for any chronic illnesses is very important to look at drug interaction. And again, to remember special population like pregnant women and children and people with immunocompromised state. So I've tried to put up the chemoprophylaxis in a tabulated form to make it a little more easier. So most importantly, with chloroquine sensitive falciparum malaria, if a traveler is going to those areas where the malaria is mainly falciparum infection and it is chloroquine resistant, these are some of the prophylaxis that can be used, mainly chloroquine or hydroxychloroquine, which is usually started prior to the exposure. So it is a once a weekly tablet, and it's taken 1 to 2 weeks, ideally 2 weeks prior to the initiation of the travel, and should be taken continuously throughout the exposure time, and even after the exposure is over, at least 4 weeks after the last exposure time. Coming to Malarone, which is the very frequent atovaquinone progonal combination. So it is a once a day tablet, has to be started at least 2 days prior to the exposure, and should be continued 7 days after the exposure is over. Mefloquine, which is routinely used and very commonly used tablet, but we need to be very cautious and should keep in mind the side effects or the adverse events happening with these tablets. So it is once a weekly tablet, which can be used either 3 to 2 weeks prior to the exposure and should be continued after 4 weeks when the exposure is over. Similarly, doxycycline and tefenoquine tefenoquine is a newer antimalarial tablet which has been introduced in the recent past. And doxycycline, we must remember the symptoms of gastritis along with these tablets. And once a daily preparation, 1 to 2 days prior to the exposure, and should be continued around 4 weeks after the exposure is discontinued. Tefenoquine can be taken a loading dose 3 days prior to the should be continued along 1 week after the trip is over or after the exposure is after the last exposure. We must remember G6 period status of the individual before prescribing tefenoquine to a traveler. Similarly, when we talked about chloroquine-resistant falciparum malaria, etovoquinone and proguanil or malarone is the most important, followed by mefloquine, doxycycline, and tefenoquine are the drug of choices and to be used in chemoprophylaxis of these travelers. Coming to Plasmodium vivax, so primaquine is important as a prophylaxis to be taken in travelers who are traveling to areas which are endemic to Plasmodium vivax, and once a day tablet for 1 to 2 days prior to the exposure and lasting to 7 days after the exposure should be taken along with chloroquine or hydroxychloroquine and malarone. Mefloquine and doxycycline and the others also can be taken to in these areas which is endemic for falciparum Plasmodium vivax. Recognition and diagnosis of malaria in a returning traveler is important, and early diagnosis and suspicion of malaria is life-saving, and it also prevents severe complicated malaria. So when we come across fever or febrile illness in a patient who's returned from a malarial endemic area, malaria should be the first thing to be considered, and malarial and the test should be performed accordingly. So correct method of diagnosis is important. It can be diagnosed either with a rapid diagnostic test. Malarial parasite on the blood smear is very important because we need to know the species and treat accordingly. So if the first smear or the first set of blood tests are negative, we must repeat at least 3 to 4 times a malarial smear or the diagnostic test to be very clear that we have ruled out malaria. Quantitative Buffy coat is another test that can be performed in travelers who are returning from malarial endemic areas. Treatment of malaria in a traveler. So usually the most common treatment is artemisinin-based combination therapy because we do not know about the chloroquine resistance, or sometimes when there is a mixed infection which is to be considered, definitely artemisinin combination therapy is important. And also, if a traveler is coming from a zone which is endemic to Plasmodium vivax or ovale, Primaquine should be followed. Definitely, G6PD deficiency has to be checked before advising Primaquine. And a mixed infection is also important to look into in a returning traveler. Then standby emergency treatment has to be initiated or given to the traveler, especially if we can predict that they may be, in spite of the chemoprophylaxis and the mosquito repellent use, they can be patient coming down with a malarial infection. In an uncomplicated falciparum infection, other treatment can be artemether lumefantrine combination or artemisinin piperacin or atovaquone progonal can also be used. So also to remember areas with resistant malaria. So chloroquine resistant malaria, usually in Plasmodium falciparum, and also Plasmodium vivax has a rare resistance, but it has also been reported to be increasing now. And this is a map that I have seen, and we are talking about these specific areas like Mekong area, Myanmar, Cambodia. These are some of the areas where resistant malaria is common, and we must think about resistant malaria in a patient who's returning from these areas. Now, Leschie infection has to be considered if there's a history of travel to Southeast Asian countries. So it is very important to know where the traveler is going or where the traveler is returning from when we are investigating a traveler with a returning traveler with fever. And also multi-drug resistant malaria, usually when it is called when it is resistant to two classes of drugs. So mefloquine resistant has been reported in Cambodia and Myanmar, where the choice of prophylaxis is limited only to doxycycline and atovaquone progonal. And artemisinin resistance is also reported in the similar areas, especially the Democratic Republic of Cambodia, Myanmar, Thailand, and Vietnam. And so these travelers have to be specially screened for, and the chemoprophylaxis or the treatment has to be tailor-made in these kind of situations. Coming to dengue fever, we know that it occurs in around 4 billion people. Around 129 countries are at risk of dengue fever, with around 96 million symptomatic cases and around 40,000 deaths each year. So these are the countries where dengue is endemic, and it is very important to remember that urban population and residential areas are more endemic for dengue compared to the rural population, and also they are the daytime biters. Aedes aegypti, they are daytime biters, so they have to be, the protection has to be during that time. And the traveler can have non-specific symptoms. Only 20% of them may become severe, and also very important to look at early signs of severe diseases. So I've just tried to put an algorithm for evaluation of fever in a traveler from Asian country. So if the fever starts less than 14 days from an area where dengue is endemic, However, it's very important to rule out malaria in these patients. So consider other causes of dengue, but yes, if it is coming from a dengue endemic area, obtain a malarial smear, do a blood culture. If the malarial smear is positive, treat accordingly. But if it is negative, try to do WBC count or the platelet count. And if it is low, consider dengue very strongly. So a strong clinical suspicion once the malaria is ruled out, and if the patient has come or a traveler has come from a dengue endemic area. So very importantly, then do the platelet count, and also do the non-specific NS1 antigen, including IgM. So it can be a rapid diagnostic test, a serological test, which can be used for dengue. And also very important at this point in time to talk about travelers who are frequently traveling to dengue endemic areas. We need to be very specific as to what is the serotype, or if they come down with a second infection of dengue or a secondary infection, then they may become sick and can go on to dengue hemorrhagic shock, or dengue hemorrhagic fever, or dengue shock. So important to monitor hematocrit and have the patient with a close monitoring and to treat symptomatically. Coming to scrub typhus, which is also one of the very important vector-borne illness in this area. So it is transmitted by the sugar of the trombiculate mite and the causative agent Orencia susokamushi, which transmits and it is usually a painless bite, so the traveler may not be aware of the bite. So these mites reside in dense vegetation, so especially travelers going to humid and warm temperature should be considered about scrub typhus. And the distribution of the arthropod-borne illness has to be kept in mind, and also the days from the travel. So when to suspect strep typhus? So presence of an eschar, which the traveler may not be aware of, as it is painless, should be one of the clinical suspicion, and around 50% of them would have an eschar present, which is a site of the bite of the sugar, and so it should be actively looked for in such traveler. Serological tests and molecular assays can diagnose scrub typhus, although the gold standard is an indirect immunofluorescence assay, but it is an expensive and a complicated test. But the sensitivity of other tests like the indirect immunoperoxidase assay or the immunochromatographic test is almost similar. ELISA tests are also close to gold standard, so they can be used with they can be used for early and rapid diagnosis. Treatment of scrub typhus usually involves doxycycline. However, children and pregnant women should be used either azithromycin or chloramphenicol can be given. Prevention of scrub typhus is important since there is no vaccine available. So avoid contact with the infected sugar, avoid areas where there is lots of vegetation, and use of mosquito repellent containing DEET can be used on exposed clothing. And permethrin also kills sugars and can be used when they are going into dense forest, or travelers which are going into these areas. The boots, clothing, and also camping gears can be treated with permethrin to avoid the sugar. There is no chemoprophylaxis, and it is a subject of controversy. However, some of the travelers which have a high exposure can receive a weekly dose of 200 milligram of doxycycline can be given to these travelers which are going into these mite islands where where they have a high risk of developing scrub typhus. Just talk about chikungunya. It is prevalent in the Asian and the American areas, and there are some reported cases in the Asia Pacific area, like Pakistan, and India has also reported around 62,000 cases recently. Japanese encephalitis is another vector-borne illness which is a risk to the traveler, and it is one of the main causes of viral encephalitis in most of the Asian countries, and around 70,000 clinical cases are seen every year. 24 countries in the WHO Southeast Asian zone and the Western Pacific zone are endemic for JE, and this also creates a risk for the traveler traveling to these areas. Quickly to talk about lymphatic filariasis and leishmaniasis, although they are not they are not acutely at risk, but people who stay long term should, these illnesses should be kept in mind and should be aware of when the traveler is spending long, many days or months in these countries which are endemic for these kind of vectors. Then to summarize, we know that international travelers are at risk for vector-borne illnesses, and it is very important to have a behavioral change which is crucial in reducing vector-borne illnesses. Pre-travel advice, as had already been alluded to, and a carefully planned itinerary is important. Risk assessment of the destination prior to travel, personal protection and use of insect repellent is important, and adherence to chemoprophylaxis may reduce the risk of the disease. Thank you so much for your patient listening.
Great, thank you very much, Divya. Look, we have run a little bit over time, but I think we've got, there have been a few questions, but I think we've got no open questions, so they've all been dealt with. So did anybody else have any questions they wanted to add? Anything specific? Karen, I was just going to mention, you talked about Dukoral and prevention of travelers' diarrhea, and that it's off license. And actually in New Zealand, prevention of travelers' diarrhea is a licensed indication for Dukoral. So for us, it wouldn't be considered off license. But as you said, it's only going to prevent a small amount of travelers' diarrhea. I'm not sure about the licensing in other countries. Yeah.
Thanks, Jenny. I know it's licensed in some European countries as well.
Yeah. I think the other questions were dealt with as we went. There was a question about Vivaxum in Australia, and Mike, did you dealt with that one?
I went ahead and answered all the questions, and I thought we may not get time at the end.
Perfect, you answered all the questions. That's great. No, that's wonderful. Good to see that you've done it. Greatly appreciated. Okay, well, I'm aware we're 5 minutes over time now. And if we haven't got any other questions, a huge thanks to all our speakers for fronting up and giving the time. It's greatly appreciated. We're hoping to run another webinar later in the year. We'll send out some information around that. I hope that you've all gathered a little bit learnt something tonight, and as this introduction to travel medicine, I'm sure for some of us it was a bit of a brush up, and as we get back into it. So thank you very, very much, everybody, and hopefully see you later in the year at our next webinar. Thank you.